Here we are.
Yes.
It's on Wednesday, which means we are gathered once again to talk about a variety of health topics. And so we want to welcome everyone to RTV.network, the Health, Wellness, and Wise, Health, Wellness, and I just added Wise, so maybe we should be wise. On Wednesday with Dr. Donna Christensen and myself, Linda Dorman. And today we have an amazing guest who has a very big responsibility with an even bigger initiative that we're going to talk about, the American Bloomberg Health Initiative. And so welcome to the program, Michelle. And how are you doing? Donna, it's so good to see you. It's been a while.
Yeah, we've been off the air for almost a month, it seems. So it's good to be back. So you're our first guest as we're coming back on. But thank you so much, Michelle, for joining us today. And for our audience, Michelle Spencer is the Associate Director of the Bloomberg American Health Initiative and Associate Scientist in the Department of Health Policy and Management at Johns Hopkins. And Michelle, I thought maybe we would start with finding out a little bit more about you and the initiative before we go into the enterprise zone, which is where I'd like to focus most of our discussion today.
Well, thank you, Donna, and thank you, Linda, for having me. It's such a privilege and to be done on and real opportunity. I am a public health practitioner. I really think about what are the issues in communities that are helping to further the gap in health disparities and inequities. I do that really thinking about what are some of the community level and innovative approaches that we should be employing when we think about the way we see these disparities in communities, particularly in under-resourced and disadvantaged communities of color. And I do that while generally thinking about that across the country. I do that with a lens of what are equitable and equitable approaches to the way we think about public health. We know that particular issues are the drivers in reducing mortality and morbidity in communities, and how do we really think about our approach and the things that we are doing to address health in community.
That's pretty substantial work, and it's a huge requirement in the U.S. And I often wonder, having worked as a non-clinician in the health field, primarily providing health education, just thinking about that was almost 20 years ago, and thinking, have we come far from 20 years ago when we had, very important Healthy People 2020 studies, trying to look at reduction of obesity and cardiovascular diseases and the associated metabolic syndromes, to now where we are talking about health inequities around maternal and child health, still diabetes, still lifetime cancers that we have lived with for so many years that we're not getting any closer to a cure, or we're managing them in such a way that we're having long of life, but is it quality of life? What do you think are some of the reasons we haven't moved the dial, and in ways that we in fact have, so to kind of leave it out on a positive?
And as you answer that question, maybe you could talk about the initiative and where your focus is, but go ahead and answer her first and then tell us about the initiative.
Sure. Well, I think thinking about both of those, right? Like the Bloomberg American Health Initiative focuses on 5 very specific issue areas: addiction and overdose, adolescent health, environmental challenges, the environment, and violence. And we know across those 5 areas that we have seen continuously a decrease in life expectancy in those 5 specific areas. And so the initiative, we were funded by Bloomberg Philanthropies at the School of Public Health to really think about how do we address those 5 specific issues that are really causing this decrease here in the US. And we do that through an approach of thinking about the research lens, thinking about education, and then thinking about policy. And how do we bring all of those things together? How do we think about how are we addressing violence? And I'm talking about all forms of violence: domestic violence, suicide, gun violence, police violence, you name it. Right? The same that we were thinking.
Yeah.
child abuse. Right, exactly. When we're thinking about adolescent health, we're thinking about adolescents as the entire population. But what are the things that are impacting the health of adolescents that we're seeing this decrease in life expectancy in that area? And we do that really thinking about how are we approaching this work? We're not just doing it as researchers, but what are some of the practice-based options that we should be employing to really think about how we continue to reduce that disparity and reduce and to increase that life expectancy. We could certainly, one of the things that the initiative does, and I think we do really well, is try to find individuals who are in the space of any of these 5 focus areas and offer them full degrees, fully funded scholarships to come and study the tools and understanding of public health practice, to get master's degrees and to get doctorates in public health degrees to really transform the way that you're doing the work. When we think about the spaces individuals are in, it's not just law enforcement that impacts violence, right? It's not just thinking about it from a law enforcement perspective, but it's also individuals who are, you think about food systems. It's not just government, it's farmers, it's individuals who are working in food deserts, who are doing this work and not necessarily thinking I'm doing public health, but we're like, you are, and we can give you the tools to think about public health differently. It's not just adolescents who are in school systems. We know that some of our adolescents are disconnected from school and from employment and family. So we try to figure out where are they, meet them where they are, and be able to employ individuals to give them the tools, again, a full fellowship, a full scholarship to get these degrees. You asked Linda, like, what's the positive way that we do this, right? Like, we thought it in data. How does our data help to inform the way we approach our work? What does the data say? We know that life expectancy for the second year in a row to decrease. That we know that was due to COVID. We know that it's due to addiction. We know that that's due to fentanyl that we see on the streets. We know that individuals need safe spaces. And so we're at a time where there's lots of different tools that we can employ and should be employing. How do we do that and that's effective, that's really meeting people where they are, and that we're seeing that we're making a difference? And, I will say lastly on this point, the policy approaches, right? Like there's lots of it. And Don, I know that right? Like just from being in government and in elected positions, that they're policy drivers to the ways that we approach this work. And so what are some of the options that we should be employing, from community-based, from policy individuals, from individuals in government, from individuals who are nonprofits in the philanthropy world? How do we come together to really think about the enterprise of socializing health in a way that works for everyone and not just for some?
Go ahead, Linda.
No, I was just bringing to mind. I thank you for actually not only sharing us more of what you do in the Institute, but then some of the crosswalk into the how. And so one of the hows you mentioned was providing scholarships so that we can create a body of knowledge. We can create experts, subject matter experts in these fields who could come back into their communities. I, as an individual, what do you think that I should be doing more of in terms of affecting what you're doing in terms of policy, in terms of you looking at the data and having that data become the informant for new policy development? How can I become smarter with some of those ways?
Yeah, that's an excellent question. One of the things that we're always saying is that we are all advocates for our own health. We are all in community with each other, and our communities look very different at times. And so I think in the spaces that you occupy, you are that change agent in that space. You are the individual who is able to say, what are the things that you are doing that affects the way that you are growing, the way that you're learning, who you're connected to? What are some of the resources within your own space? What are some of the challenges? We know that gun violence is an issue here. It's an issue everywhere, but it's certainly a prominent issue here in the US. And we see that, unfortunately, continuously. We saw that last week in Nashville, in terms of what's happening in that school. We see it's continuous. And so there are opportunities that we go before the legislator. There are opportunities that we go within our communities, licensing, right? How do we think about licensing laws as it relates to access to a firearm? I'll use that as just as a small example. We know we have ERPA laws. ERPAs are extreme risk protection orders. And we know that if there is an individual that we know that has a firearm that can cause harm to him or herself or to others, we as individuals can petition the courts to say, I have a colleague, I know someone in my space who I am afraid that they're going to use their firearm. And that the courts are then able to go and, for a moment of time, remove that firearm from that individual until we ensure that that individual is safe and can safely handle that firearm. And we have questions around constitutional rights to carry, et cetera. But we're talking about, if we see as individuals that a person is not able to meaningfully handle a firearm, we have tools that we can use to say, I'm afraid for this person's safety and those around them, and we can petition the court. And so there are a number of ways, right, to do that. But Linda, I think more even to your question, how do we as public health practitioners ensure that that information is out there so that folks are aware that that's a tool that they can use?
And I'm so glad you said that. And I want you to say it really slowly for our listeners and viewers to go grab their pen and paper and actually write that acronym down and find out about their local court system's ability to do that, because that was a very new term that you just educated me on. Can you repeat that base of information? Because that's something that I can do and look out for if ever I'm in that situation.
Absolutely. So it's called ERPO, ERPO. And it means extreme risk protection orders. Sometimes they're called DV orders, domestic violence orders as well. And so, again, when you use community, we know that's IPV, intimate partner violence. We know it's domestic violence, suicide, etc. And so that's a tool to be able to say, I'm afraid for a family of friend who may be using this, who may, have this firearm. And so we think about what is the opportunity there as well.
I appreciate that information so much. Donna, my head is spinning with a million questions, but I'm not going to dictate everything, but I'm going to let you go.
I was just going to ask, as a follow-up to the question about how far have we come in closing those gaps and achieving equity, how has, if at all, the executive order that the president signed on his first day regarding equity, have you felt any impact, seen any impact from that yet?
And Donna, for our listeners, are you referring to the executive order that called for ensuring that we advance equity throughout all of our government agencies and therefore the services that are provided?
And the services, yeah.
Okay.
The services. I'm seeing a lot of work on diversifying the workforce in the government agencies. I haven't seen much in terms of how we're impacting a community, though, otherwise.
I think so. It's exciting to know that within hours of President Biden taking office, that he recognized the importance of equity and inclusion in the work that is done throughout the country, right? We always talk about the United States is diverse. We are we come with our experiences from far and from near, and the way that we approach the work and the way that we must do the work is not through a single lens, but must be inclusive of the folks who make this place America. And so I think it not only was it something that we all were excited about and excited to see, but then we also think about how that translates into every agency. We think about the transportation agencies and thinking about how do we get meaningful transportation in rural communities, in urban communities, in suburban communities. What does that transportation system look like? How do we ensure that individuals who need to get from point A to point B, right? Transportation is not just about being able to travel, it's about traveling to jobs, to
getting to the
employment,
doctor's office.
getting to a doctor's office and getting there safely. Transportation that is feasible and accessible and doesn't take hours to commute from one place to another. And so I think having President Biden being very clear about this is the way that we're going to, his administration is going to approach the work with this holistic vision of not just an America that's for one, but an America that is for all. And we're going to do this by thinking about all of the different sectors, from health and human services and transportation and EPA, the environmental protection agencies. How do we think about the way we're doing this work in a transformative way that allows us to think about the tools of access for everyone? And so, all of these laws that are coming that are now in the books, right? But change takes time. And I think that is one of the things that we constantly have to remind ourselves. That, when I think about the work of equity and diversity, I think of a turtle, right? Like, it is slow, but it is progressing, and it's taking the time. It knows where it's trying to go, and there's lots of ways to get there, but yet to be consistently moving forward, and you're moving against pressures, and you're moving upstream against historical systems of all sorts, right? Like oppression and racism and structures that haven't doesn't benefit the whole. And so we're in 2023, but Linda, to one of your initial questions, it's 20 years and we're still talking about equal rights and even equal pay. We are in the middle in 2023 dealing with women's rights. Like, who would have thought, right, that in 2023 we are talking about a woman's right to choose and a woman's right to do what she sees fit for her own body. And so policies make a difference, and yet we know that these things are taking time, and these things are we see like the constant need to revisit and the constant need to fight for these basic rights.
And I'm glad you asked that question, Donna, and thank you, Michelle, for that thorough answer, because what I don't think that people are connecting the dots on is, at my level as a taxpayer, how that feeds into the national budget that then President Biden lifted up and expanded, and just recently communicated in March. So anyone who wants to visit and understand how are these various inequities being addressed from a budgetary perspective, and how much money, how many hundreds of millions and hundreds of billions of dollars of how our funds are being allocated to support equal access to education for children who are in underserved communities, with $1 billion in the Title I program still. Having new initiatives and new sub-agencies, if you will, really form with the investments made in child and maternal health. That strikes me as, that was one of the number one that strikes me, that there would be that level of support. And I pulled it up because I think it's so important to share. $471 million to support implementation of a White House blueprint for addressing the maternal health crises. And I know that you touch on this and you work deeply in this particular space. It baffles my mind how the mortality rate has decreased when we did so many things to help it move the dial and have in an industrialized and a very high developed country as the United States of America. I'm in shock about these kinds of issues that we're still wrestling with, and can't and feel like I need to find the root in order to at least bring some logic around it so I can understand. But I appreciate that what you're doing is to put a spotlight on it and educate and develop the tools and resources and the policies and the skill sets to push this critical information out into the public domain such that we can actually execute and actualize on it. That's really important to me, and I'm sure to Donna, and I'm sure to all of our listeners who are growing in their body of knowledge in this area.
So I noticed that the president also has issued a secondary part of that order recently. And finally, it seems as though the focus is going to be on the communities to be served, which brings us to what I really want us to talk a little bit more about. Back in 2003, we introduced a piece of legislation called Health Empowerment Zones. And it was a way to address health with the inclusion of the social determinants of health. Now, it still hasn't passed the House. Former Congressman, now Attorney General Anthony Brown actually reintroduced it as a standalone last year, but it's been introduced within the Health Equity and Accountability Act in every Congress. But we didn't pass it, but Maryland did.
Yes.
Anthony Brown was the lieutenant governor at the time, and the then delegate Shirley Nathan Pulliam, now retired senator, was in charge of the health committee. And so they created health empowerment zones. And that's how I got to know Michelle, because I kept trying to follow them. And there was a nice article, I think it was in the Post, about some of the efforts and the successes of at least the health enterprise zone that Michelle is leads. So can you talk a little bit about what we might see from if there's an emphasis on working with the communities to find out what needs to be done to create equity?
Yeah, I love that question. And the health enterprise zone, I think, is one of the foundational initiatives that I've worked on, and I'm always humbled to talk about it, particularly as you just noted. Then Anthony Brown recently in the 117th Congress reintroduced legislation again to have that. And so I am across the state, right? And so Maryland, we are fortunate. As Dr. Christensen noted, back in 2012, it was Senate Bill 234, the Health Improvement and Disparities Reduction Act, that brought us the Health Enterprise Zone Initiative. And, it was a pilot program. The legislature gave us $4 million every year for 4 years to across the state to think about how we implement this community level, community-based initiative. And what was great about it is that we had 19 applications. We had 5 that were funded, and all 5 looked different. They were in urban areas, they were in rural areas, they were in suburban areas, they were in Baltimore City, they were on the Eastern Shore, they were in St. Mary's County, in suburb, and so they were in Prince George's County. I mean, absolutely amazing. And what we realized, and what we learned over the 4 years, they were in community-based organizations. I need to mention that they were in hospital systems, they were in local health departments. And so what I would want you to take away from hearing about the Health Enterprise Zone is that it can happen in any and every community in our state. And this can be replicated in other states, and it has been. And it's been really a beautiful honor to be part of it. I will share with you that the legislation required that we reduce health disparities, that we improve health outcomes, that we reduce hospital cost, as well as hospital admissions and readmissions.
Yes.
We can come back.
Worked in a hospital. I was a VP of philanthropy in a hospital system. I'm going to be excited to have, let's do a little deeper dive when we come back from the commercial break.
Yeah.
And
spend the rest of it talking about this.
Definitely do that. So thank you for those who are tuning in and come back. This has been Health, Wellness, and Wise programming here on OurTV.network. We'll be right back.
Time. It has a different meaning in the U.S. Virgin Islands. It goes backwards, forwards, it stops. St. Croix is rooted in history. So much of it still remains untouched.
I remember running on these streets as a kid. This trap was right down there. It opened the same year I was born. This is where the original Crucian hook was born. It's the symbol of these islands. And I wanted to have my hands in that very same history. I want to be able to pass it down to my family while still putting a new spin on it.
The U.S. Virgin Islands, we have an amazing culture that developed over time from all over the world.
St. John feels so untouched. Being underwater is like another world. There's no worries, there's no stress. I can just escape. This is my happy place. My passion for scuba diving came at just being fascinated with the water and wanting to be a mermaid. And this is the closest thing I can get to achieving mermaid status. Canadians just love being outdoorsy. We live for adventure, so we love anything hiking, being on the water, diving, snorkeling, and St. John has it all.
It's like some spirit is protecting the island and keeping them raw. The Makujumbi watches over the island. From up there, they keep the evil spirits away. The nightlife in St. Thomas is absolutely amazing. There's always something going on. Everyone comes together to dance and catch a vibe. We're always celebrating. We celebrate freedom, culture, the food, the smell, the music. It's always a celebration. The people here are probably the most priceless thing because they keep the culture going. There's so many different influences on these islands. Food from all kinds of countries coming together in new dishes. All of us came from somewhere, but all that we call this home. The VI is a new melting pot. This is where the past and the future comes together.
welcome back to the program. And I should say, if you had a chance to just immerse yourself in that commercial,
Yeah.
it's real nice. And Donna, are you in the Virgin Islands?
Yes, I am. I'm in St. Croix.
You're in St. Croix. Well, that's real nice. And we're in Maryland, so we hope to visit you down there. But welcome back to the program, Health, Wellness, and Lifestyle. I keep saying wise because we're getting wiser right here with on OurTV.network, Amazon Fire TV, Android TV, Apple TV, Roku, and I should also add WSTX Bloomberg Radio. So that's where you can hear us and see us and experience our wonderful, amazing guests. So we are here with Michelle Spencer, and we're just getting ready to do a deep dive into the health enterprise zones.
Right.
Because I'm not sure individuals understand that, but I'm glad we're in Maryland, that we are at the forefront of developing these
absolutely
geographical areas that get extra funding to support and reduce health disparities that we know are clustered in these areas. So let's continue that conversation. So tell us exactly what is a HERTZ or a health enterprise zone. So we kind of break it down for our listeners, and we can kind of dig deep a little bit more into how Maryland is bringing that to life.
Sure. And so thank you for that and for that question. And I will say that I too, Linda, am looking very much forward to visiting Dr. Christensen in St. Croix or St. Thomas.
And helping us as we start one, which I'm still waiting, Michelle.
Oh, awesome. I'm ready whenever you are. So the Health Enterprise Zone Initiative, I think right before the break, I noted that it was established through legislated action back in 2012 under the title, the Health Improvement and Disparities Reduction Act. And the act really required us to reduce health disparities, improve health outcomes, reduce hospital cost, hospital admissions, and hospital readmissions. And I'm just going to pause there for 2 seconds to note that reducing health disparities and improving health outcomes is something that you can't necessarily do in a 4-year period of time. We can certainly try, but again, as we said earlier, there are structural elements and systems that have been in place and perpetuated for years and years and generations that within 4 years, it's like, how are you actually going to do this, right? But Marylanders are resilient and innovative and very much thinking about how do we push ahead in spite of these historical elements. And so what we were able to do at the state and with the funding that was given and afforded to us, we had 19 applications from all across the state. We selected 5 specific organizations to tackle this work, who showed that they had persistent rates of infant mortality, that the disparities or the gaps were wide, and that there were opportunities based on what they were presenting to really help to reduce those disparities, as well as high increases in admissions and readmissions. And so what we did is we awarded these 5 areas, again, all across the state of Maryland, different dollars, right, based on what they requested. And I will say that at the time of implementation in 2012, we had the broader healthcare environment that was also at play. So at that time, the Affordable Care Act had just passed. The Maryland, we had Medicaid expansion. And we also implemented global budgets. And global budgets in the state of Maryland required that the hospital, if you were discharged and readmitted within 30 days, the hospital would not get paid for that readmission. And so the incentive was about the value and quality of your care more than the volume of care that was coming into the hospital. So at the time that the ATZs were passed, we know that the ACA had just passed and we had just finished our first enrollment, so more people had access to healthcare services. Medicaid expanded in terms of the services that they were providing or allowed, and we had global budgets, which were critically important. And so what we were able to do, and I could get to the punchline if that would be easiest for our viewers, or I can continue to walk you down this road.
We have about 20 minutes. Oh.
Okay.
Whatever.
Okay, I'm gonna walk us down this. Okay, I'm gonna walk us down the road a little bit,
And then can I
and
add one
then
more thing to what you said in terms of the readmission piece? I worked in a hospital system that was part of that opportunity. And so one of the things that we had to do was to really strengthen our community network of health providers out in the community outside of the hospital structure. So if you still needed services because you walked in with a broken arm, but you somehow wound up with a broken leg and you came back in 30 days, that readmission was not counted. So we would need to be able to determine how we can best make sure that you have resources for if you were a fall risk. Has someone come to evaluate your home as an example? And I think that's what, when you walk us down, I think that's what our listeners need to understand. How does this apply to me, and why is this so important in Maryland? And the incentives, and how that incentive maybe is translated into lower tax base, how that incentive is ultimately in the future, hopefully lowering our health costs while bringing up that value, as you mentioned. So I get excited. I just
Linda,
feel like
thank you.
this conversation.
Yeah. And I so appreciate your noting, because critically important is care coordination. And so at the time of discharge, certainly hospitals and healthcare systems can send you out the door and wish you the best. But through the HEZs, it was very clear that individuals needed to have their care coordinated in the communities in which they work, in which they live, in which they play, in which they worship. And so being clear about that, as an individual that was discharged from the hospital, we asked those questions. What are your care needs? What's going on in that home? Do you have, what does the food system look like for you? What does paying bills look like for you? Do you have a person that can support you if you needed to go in and outside of the home? What does that look like? What are the things that are important to you for your health recovery? And so we know that clinically, there are very specific things that we would want an individual to do, but what are some of the things that are incentivizing you? That we ask those questions all the time. It may be, I want to be able to go to a loved one's graduation. I want to be able to attend this family reunion. So how do we ensure that we're giving that individual the resources within the community to ensure that they're able to do those things, that they're able to meet their own individual goals outside of the clinical priorities that as a healthcare institution and as a providers that we know we have to focus on? What are some of those other personal and social goals that
Right.
that
we often talk about meeting people where they are, being so important, as well as
Yes.
the community driving also what happens in these zones.
Absolutely, right. And how accessible is healthy foods in the community in which that individual is going back to, as a key component. And so I will tell you that the zones were all different. I think I mentioned that. And so what Baltimore, we were at Bon Secours Hospital. What Bon Secours Hospital did was very different than what Prince George's health department did. And I want to lift up Prince George's health department for just a moment, because one of the things that they did, to your point, Linda, about coordination of services and care, is that they developed this team. It was called like the care coordination team. And so they had fire department, they had law enforcement, they had social services, they had individuals from the school system, like you name it. Every week they came together to talk about who were the individuals that were calling in to 911 for services. And 911, right, though the EMS would come and take individuals to the hospital, but let's pause and see why are the reasons that they're calling. And maybe those reasons are not just clinically based, but maybe there are other things that are going on. So within our CCC team, what are some of the things that we can identify that helps to reduce those 911 calls and helps to reduce admissions and readmissions? And we saw that decline. Yes, please, Linda.
And I'm so excited because I sat with my executive, I was around the board table, member of that team, and we talked about that very subject, our frequent flyers, as we said, and the level of expense to the hospital system when you're a safety net hospital. We can talk about what does that mean. And in these HERTZ areas, and those who qualify are probably in the safety net hospital versus the expensive private hospital that can turn you away, but the safety net hospital cannot. And so what we did as a result of that work group was to actually deploy our nursing crew when those calls were frequent flyers, so that maybe we can provide services to that potential patient in home, make that assessment, and then with the paramedics determine, yes, is this urgent enough that it needs to come to the hospital, or can we address it outside? Very innovative, it sounds quite simple, but the cost reduction and the cost savings to all of us was pretty substantial. I appreciate that so much. I'm just getting excited. I need to calm myself down because I love this conversation so very much. It reminded me of how important this work is and how much work that you do is so critical to the individual health consumer. Sometimes we think it's so far reach, but it really is not. It's something that we always have some base of knowledge around. So let me let you.
You know, I'm so glad that you lifted that. You know, I'm going to go to this punchline for a second and we can come back. But I shared with you that the state provided $4 million over 4 years, right? So that was a $16 million investment, which is a lot of money, which is a substantial amount of money to have a pilot program for 4 years. Like, how is this working? How is this, has this really made a difference? And what we realized at the end of 4 years, we had evaluators from Hopkins Hospital who were economists, health economists that came in, and it was Dr. Daryl Gaskins. Yeah. And Dr. Gaskins, you know this, Dr. Christensen, what Dr. Gaskins found was that, and said it, and there's an article in Health Affairs, I think from 2020 or 2021, that said the net savings from reduced inpatient stays far outweighed the initiative's costs to the state. And so the net savings, the drum roll here was we invested $16 million. And it was a total of $181 million savings to the system, to the entire system. And so I always get excited about that and thinking a small investment, and it's not insignificant. 16 million is not insignificant. But when you have your return on investment, doubling that amount, tripling that amount, quadrupling that amount, you can't say that this did not work. And so so that's one piece that I'm always excited and thrilled about, to be able to say this $16 million investment in 5 communities across the state of Maryland helped to reduce inpatient admissions, helped to reduce inpatient costs, and even helped to reduce some of those disparities in those communities. Because one of the things I did not mention is that to be a zone, you had to be within contiguous zip codes. So it wasn't that we did within contiguous zip codes in that specific area. So while we may have been in Prince George's County, we were in very specific zip codes in Prince George's County, so that we can track, right? It had to be big enough that we did not identify individuals, but small enough where we knew that we could make a difference. And we saw the difference in the data that showed us that we reduce admissions, reduce readmissions, reduce hospital costs, and that we did in fact help to reduce disparities in those issues, in some of those areas. And to be very clear, what I said earlier about, it's hard to think about going up against historical systems and actually seeing outcomes. And to be able to see that in a 4-year period of time was pretty tremendous.
And I think we should note in all those reductions, which is extremely important and positive, because it just trickles down to the individual health consumer, is that it was not sacrificed for quality of health care. Quality of healthcare, because those cost savings translate into new opportunities to bring in and attract the best and brightest into the healthcare system. That's going to continue to increase and enhance and improve healthcare outcomes. That saving also translates into innovation, research, and residencies in innovative and researching programs that aren't necessarily coming into the brown and Black and BIPOC communities. You know, we're not community hospitals. We're large, the hospital system I work for, we built a $563 million hospital so that we could take advantage and elevate the quality of healthcare, bring education and research, and then create a training institution for the residencies that were coming and will be our future doctors and clinicians. So
note on that
when
point,
you started out, it was new to the community. So how did you introduce this to the community as you started out? To anyone?
Yeah. Well, that's a great question. And if I can just go back to Linda's last point, which is phenomenal. One of the things that the Senate Bill 234, the legislation, required was that there were incentives to healthcare workers. And so incentives for paying for their tax credit, repayment for their loans. So very clear that we are, to your exact point, care was not compromised in any way, but rather we were able to look at communities that didn't have that. We call them, help me, the
healthcare desert sounds like.
Right. Yes. So where we don't have a high level of practitioners, we were able to recruit practitioners to come into those areas, to have even more of a presence by offering them the incentives of repaying their school loans and their medical loans. And so that's one. Thing that the HEZs were able to do was to expand clinical care. So Prince George's County, there were 5 new sites, 5 new FQHCs were either 5 new sites were either expanded or built in Prince George's County. And we did the same in St. Mary's County as well. Very clear that we need to create more spaces, more opportunities, and certainly increase the number of practitioners in the areas as well. So I just on your last point, Linda.
That's important. That's very important.
I can tell we're going to need a part 2 anyway, so let's just keep on going. We're going to do part 2. This speaks to how do we address the level of healthcare and the expense of it universally. And I think that our consumers and our listeners and our viewers are participants in this conversation in ways that I'm not sure that they really would grasp in just a short hour of time, but that through your the work that you're doing and the public health as a sector is doing is critical. It's absolutely critical. It's for the young people to see on TikTok if we have to boil it down to getting it into apps or out here.
As long as we have TikTok.
As long as you have TikTok. Well,
I know there are other things.
Yes, any social media in form or fashion, absolutely. In a program like this one, health, wellness, and lifestyle for sure. So you had asked the question, Donna, while we have about 7 minutes left in the program.
Yeah. So a new program in a specific community area of Maryland that needs to be community driven. How do you how was it accepted? What are some of the techniques that you use to bring this information and engage the community in the process?
Yeah. So such a great question. I think I'll answer in 2 parts. One, when the RFP went out, the RFP required that whoever was applying had to do that in collaboration with individuals in their community. So we had lots of focus groups, we had lots of workshops to be able to say before any applications were due, we went across the state to say, this is what we're doing. We have this opportunity to support however many of these zones, and we want you to get with your community leaders, get with your faith-based leaders, get with your hospital and your clinical providers to talk about what is the opportunity here. We've provided the tools. The state provided a dashboard to say all you have to do is go in and put in your zip code. And when you put in your zip code, what you will see is what does life expectancy in your specific zip code look like? And what are some of the contributing factors? And so we were clear that the state was only we only saw ourselves as the facilitator of getting the information to community so that they can tell us what it is that they would do, understanding what the specific issue in their area was within their specific zip code. It could be housing, it could be food insecurity, it could be infant mortality, what the drivers are. Could be cardiovascular disease. And so we created the tool, provided that to community, to anybody that wanted to go in and take a look. And then they used that to be able to say, we're going to write our application and say that we're going to focus on reducing infant mortality in this specific zip code, reducing diabetes, reducing cardiovascular disease. And so that was one way before. And then post, once the awards were made, we created space for those communities to come together so that they were able to say, we've just been awarded X amount of dollars to do this community-driven innovative approach here at Prince George's County, or here at St. Mary's Hospital, or here on the Eastern Shore. And we want to be able to, and what we want to do is to talk to you about what services this grant is going to allow us to provide. And so if you need to get from the Eastern Shore to get up to Baltimore, and transportation is going to take 4 hours, we're going to figure out how to use the dollars, that the funding that we have, to get you to Baltimore in an hour, that it would generally take anyone who has access to a car. And so we were very intentional about how we communicated that, because again, the outcomes were, it's data driven, and the outcomes were such. And so I know we don't have a ton of time left, but let me just tell you the outcomes from that 4-year pilot project. We now know that we have the HERCs, the Health Equity Resource Communities. So that $16 million has now translated to $60 million. That we now have across the entire state of Maryland. And we have done that and expanded that in 9 additional spaces and counties in the state of Maryland. We have the Prevention Link program. So I don't want us to miss that point. Yes, please, Linda.
No. I want you to get your full point out, because that's really critical and important. So
yeah, and so my full point there is that we took $16 million with that pilot investment and went back to the legislation in 2021, went back to the Maryland General Assembly, talked about what the incentive did. We had Shirley Nathan Pulliam then advocating, and Dr. Christensen advocating, and Lieutenant Anthony Brown coming back and saying, this is what we were able to do with $4 million. And we saw that through the Black agenda at that time, we got $60 million for our new legislation called the HERCs. And so
really quickly, as we sum up, is that Maryland was the only state that this was this model. So we're hoping that it gets replicated to all of our listeners and viewers in your area. So talk to your local health departments, talk to your legislators at the state and federal level, so that you can understand what kinds of resources and how do you advocate as well. What do we need to do to get these allocations and appropriations for HERTS in your communities?
Absolutely. We're going to try to do the same thing in the Virgin Islands. It's already sort of catching on in some of our low-income housing communities through a different program. But the Department of Health has some health equity funding, and they're looking at neighborhoods that they can begin to work in, and we're awaiting our grant funding to start in a neighborhood in St. Croix. So, and we'll be asking Michelle to come and help us get started.
Well, we want you to, Dr. Christensen, it's always a pleasure, and Michelle Spencer as our special guest, Associate Director of the Bloomberg American Health, I'm going to get it, initiative. There we go. Yes. On our TV. We're just OurTV.network, powered by Roku. So we are excited. We thank you, and we look forward to a part 2, and everyone get into the know.
Great success story.
Thank you.
And more to
Thank
come.
you.
More
Thank
to
you.
Thanks for having me. Yes.
Take care.
Thank you
Thank you.
for having
Thanks.
me.